Unplugged in, treating COVID-19. Nearly 40 million people around the world have been infected with the coronavirus. More than 1 million have died. President Donald Trump says he thinks he has been cured.
And now I'm better, and maybe I'm immune, I don't know.
Medical experts are a bit more cautious. We examine coronavirus treatment options from therapies to vaccines. Unplugged in, treating COVID-19. Hello and welcome to Plugged In. I'm Greta Van Susteren, reporting from Washington, D.C. A week after his battle with COVID-19, President Donald Trump says he is no longer contagious with COVID-19, and he's now back on the campaign trail. His opponent, former Vice President Joe Biden, is criticizing President Trump's quick return to large campaign events as reckless. In the United States, since the beginning of October, the average number of daily cases is up 15%, with outbreaks in the Northeast and the upper Midwest. October 1st marked the beginning of flu season in the Northern Hemisphere. The World Health Organization estimates 290,000 to 650,000 people die from the flu each year. Doctors are concerned that the intersection of the coronavirus pandemic and flu season will test the limits of the global healthcare systems. Here's VOA's medical correspondent, Carol Pearson.
Doctors say it's more important to get a flu shot this year than ever before. The CDC says anyone 6 months or older should get the vaccine.
We anticipate that there will be some people coming up who have both COVID and influenza at the same time, which would be very devastating, obviously, and increase the risk of death from one or both of them. So anything we can do to prevent influenza and to prevent COVID, of course, we want to do.
Both are respiratory viruses. Both can be lethal. And flu season is practically here.
We are going into this flu season with both hands tied behind our back. And we are also working in a climate where trust in vaccines continues to erode.
The CDC reports a sharp drop in routine childhood immunizations because people are afraid of getting COVID-19. But doctors say there is nothing to fear.
All of the healthcare facilities are taking extra precautions to make the environment safe for people who come in.
Even when there isn't a pandemic, Professor Van Susteren says people justify opting out of getting a flu shot.
The flu vaccine is not always the most effective vaccine, so people use that as an excuse to not get the vaccine.
In recent years, we've been anywhere from probably a low number of 20% hit, and we've been as high as 65% successes.
Experts say even an imperfect vaccine can reduce the severity of infection.
There are also a number of myths associated with the flu vaccine, like getting the flu vaccine will actually give you the flu, which is not possible because the virus particles in the flu shot are dead, so they cannot multiply and give you infection.
CDC data shows that during past flu seasons, 80% of children who died from influenza were not vaccinated. And research from Duke University shows only a third of American adults got a flu shot in 2018. Young children, pregnant women, older adults, and people with underlying conditions are most at risk for hospitalization or death from a flu infection. African Americans and other minorities have a higher risk as well.
It worries me a lot that communities that are the hardest hit by COVID are also very heavily impacted by flu. And we know that vaccination rates are lower in these communities.
Van Susteren says doctors need to work with community leaders to let people know that the flu vaccine can save lives. She says the vaccines also have to be accessible and free of charge. Carol Pearson, VOA News, Washington.
Despite the general availability of a seasonal flu vaccine, the U.S. Centers for Disease Control estimate as many as 62,000 people died in the United States last flu season. Although there is no approved coronavirus vaccine, doctors, as they see more patients, are developing therapies and protocols. For President Trump, an experimental therapy was used. During his 3-day hospitalization at Walter Reed Medical Military Center, President Trump's treatment plan devised by his doctor, Sean Coney, included the antiviral drug remdesivir, dexamethasone, a steroid used as an anti-inflammatory agent, famotidine for stomach acid, zinc, vitamin D, melatonin to help with sleep, aspirin, brief supplemental oxygen, and the commander-in-chief received a dose of an experimental antibody cocktail developed by the drug maker Regeneron. Last March, the death rate in hospitalized patients was twice what it is today. Dr. Monica Gandhi is a professor of medicine and an associate chief of infectious diseases and global medicine at the University of California, San Francisco General Hospital. I spoke to her about what we have learned by treating patients with COVID-19.
I mean, in March, we actually had nothing. And it felt like the beginning of HIV, because I'm also an HIV doctor, where you had nothing to offer someone. It was awful. And so instead, we would just do supportive care, which means giving them oxygen and turning them over, which can help people if they're lying on their front, help people get better oxygenation to their lungs, and just keep them clean and do sort of routine care. But there was nothing specific to do for this virus, which felt terrible. And it was part of the reason that hydroxychloroquine and treatments that could in a test tube look like it could work against the virus, we just gave freely to patients because we didn't know what else to do. Now hydroxychloroquine has been studied in enough trials that we know it doesn't work. But there was such desperation, you feel so helpless that you're giving anything that could work in a test tube. Now the situation is different. There is, for severe disease, steroids, which is amazing because it's cheap and available and everyone can get it. It's not something that a drug company is going to charge $3,000 a month for. And that was exciting to have a treatment that is globally available. That's only for severe disease. Second is an antiviral, which is remdesivir, which does cost $3,000. I mean, it is not going to be and isn't available globally. And then third, what we've heard of recently is these monoclonal antibodies, which are very experimental still. They were given to President Trump, but that was still not approved by the FDA. These are still in trials. But there's biological plausibility why an antibody directed against the virus itself could help your immune system fight that virus. And those are hopeful, but they're not available for most people.
Some people are what we call long haulers, is that they develop COVID-19, they get sick, it seems to be handled or finished and done, but then we start seeing them having other medical problems. Is there any sort of thought about that? What percentage of people are long haulers?
It is this phenomenon of long haulers is not yet described as well as it will be. What I mean by that is that there's a lot of anecdotal, a lot of people not feeling well afterwards, but the quantification of that, we need more precise estimates. The one good thing about this, one's idea is that could these symptoms go away, is that this is an RNA virus. And it doesn't stay in your body. HIV stays in your body. HIV is what's called a retrovirus, and it actually intercalates into your very chromosome, and you need lifelong therapy to combat HIV. But the coronavirus is an RNA virus. It will leave eventually. It will leave. And then it's your immune system that is causing these longer-term symptoms. And now we need to figure out what we should give for that. How do we shorten that course? And hopefully symptoms will resolve over time.
Is there something when you look at the coronavirus you can say, yes, this one is not going to change, so that when we do get a vaccine that we know that we got it?
Yeah, this is a great question. I mean, we've never developed a vaccine or needed to against coronavirus because the only other severe coronaviruses, MERS and SARS, stopped in their tracks from before we had a major worldwide problem, in the sense that SARS, the first virus in 2003, had 8,098 cases worldwide, but it was 8,098 as compared to 35 million and counting here with SARS-CoV-2. And it was, so we haven't had to do this before, a worldwide vaccine against a coronavirus. On the other hand, the coronavirus does not change. It's an RNA virus, so is influenza, but it doesn't change its surface to the same degree as influenza does. So that's hopeful. Coronavirus is mutating. This one is mutating, but it doesn't change to the same extent. And these vaccine candidates that we have out there, mRNA, one's an mRNA vaccine candidate, one's proteins on the surface, don't seem to be in areas that we've seen major changes with the coronavirus changing itself to evade those vaccines. So I'm hopeful that the coronavirus vaccine is not going to be something that you have to get every year like we do with the influenza vaccine, and that it will give us durable immunity.
It's when I see these outside door events. I mean, the recent one at the White House, which we've now categorized as a super spreader. There are people outdoors where there's great ventilation. They didn't wear masks, and they were in close contact, but they were outside. Is it possible? And can you tell whether or not even the virus that the president had was the first one, or one that has mutated slightly or somewhat, and that may be his, because he appears to have recovered rather quickly.
In the case of the president, I think that he may not have had the viral. For a while, I thought he would have had a lot of viral inoculum because he doesn't mask consistently. But it's true that this vent was outside, and that would wave the virus away and make it so that you don't get as much of a viral inoculum if that's where he got the virus, is one of these outside events. He got a lot of treatment, and that also could have prevented him from having a severe manifestation. He got this experimental monoclonal antibodies, and they do have biological plausibility to think that they're going to work to prevent severe disease, not to treat severe disease, even though they're being studied in that way too. In his case, he got them to prevent severe disease because he, wasn't yet in the hospital. He wasn't yet having high amounts of oxygen that we would think that's what you need for to qualify for steroids. But giving someone an antibody itself that's very specifically designed for coronavirus could really have been the trick for him. I don't know, actually. He also got lucky. Lots of things happened. This is the bizarre protein manifestations of this disease. We don't know that special ingredient that some people get very sick and some people don't. And yes, he got lucky, and he seems to be doing well 12 days later.
In the beginning, we were all washing everything that came into our house, wiping down boxes and bags and everything. And then that seemed to as time marched on, is that we were told that the virus couldn't survive on a surface particularly long. Then I read the other day the Australian National Science Agency has now concluded that this virus is extremely robust and can last 28 days on a surface, and that their study has even been peer-reviewed. So where are we in terms of whether we should be wiping off everything that comes into our homes, and how long can this virus last on surfaces?
Where we are with that is that don't be scared of surfaces. That's what I want to do, is the ultimate message, because even if the virus can exist on surfaces, which is true, the Australian study that you just mentioned, and human skin, the virus is in such small amounts that is not the main route of transmission. You would have to actually have 100 people cough on a surface, then in that wet surface, grab it with your hand and stick it right in your nose. Really, it takes a certain number of variants for you to get sick. We should stop wiping down every surface. That's environmentally not good for the environment either. And think about the main way, which is respiratory spread, and cover the nose and mouth.
Doctor, thank you very much.
Thank you very much. Thanks for having me.
Businesses are searching for tools to use to make it safe to bring back employees and customers. Among the tools, a thermometer to take people's temperature before allowing them inside. For businesses requiring large numbers of people, handheld thermometers is impractical and certainly not perfect. VOA's Elizabeth Lee shows us how innovation is adapting to the pandemic.
In this COVID era, many businesses, such as this salon, require guests to first pass a temperature test with something like this before entering.
Temperature is 97.1.
Temperature screening is something that we should do in perpetuity, but we can only do it with automation.
Many businesses that expect heavy foot traffic are looking for COVID deterrent devices that can screen temperatures quicker to get more people through the door efficiently. That's where thermal imaging systems come in, and everyone seems to want one.
Schools, theme parks, sports stadiums.
Although temperature-taking technology does not diagnose disease, and not everyone with COVID-19 has a fever, global demand is skyrocketing.
We were originally shipping, like I said, 10 a month, and we're up to about 100 a day.
Many companies, including Thermal Technics, have developed infrared cameras that read body heat.
An infrared camera is about 110,000 of those point-and-shoot cameras. They're not shining a laser, they are waiting for the heat to hit them.
Flair says its temperature screening devices, including a camera, have become more efficient through the years.
Now you're seeing more machine learning and artificial intelligence to help automate pieces of that screening process, which allows for faster throughput and consistent accuracy.
Instead of a camera, ThermalPass uses infrared sensors to read your body temperature.
There's no risk of it not measuring at all points in my body.
The company Cognits offers an infrared and an optical sensor, along with a camera that not only screens body temperatures, but also detects whether someone is wearing a mask or keeping social distance.
So it becomes a completely automated platform.
While temperature-taking devices can be a deterrent to disease, health officials suggest more testing to diagnose COVID-19. Elizabeth Lee, VOA News.
While temperature readings may be part of the new normal, health experts say critical updates to the buildings we live and work in could also help slow the spread of diseases in the future. Dr. Joseph Allen leads the Healthy Buildings program at Harvard University's T.H. Chan School of Public Health. We spoke about the impact of buildings on our overall well-being.
We have been in the sick building era, meaning our buildings have not been designed to help protect us from infectious diseases. So we chronically underventilate our buildings. We use low-level filtration, and many buildings are finding that to be a problem right now, whether it be office buildings, schools, in an airport. Every indoor place that we spend our time are usually underventilated and have low level of filtration. We need to change that. So we've been in this era for the past 40 years, really, where we've stopped designing buildings for people. As crazy as that sounds, we've stopped putting human health at the center of our decisions around how to design, operate, and maintain buildings. And we're seeing the impact of that right now with COVID.
In airborne transmission, is there a way to quantify how long, like a coronavirus can say suspended? I mean, how small is it? How long does the area remain threatened?
Yeah, it's a really good question, Greta. I mean, if we think about even for a cough or a sneeze or just talking like this or just breathing, we emit a continuum of particles of different sizes. Some will be very large, like you might see a singer spit, right? And these are going to settle out due to gravitational forces. But the reality is that most of the particles are small, and even the larger ones rapidly evaporate and become small particles. So there's been this misunderstanding, largely going back to medical textbooks that are decades old, that a 5-micron particle, that's the size of the particle, will settle out in 6 feet or 2 meters. That's where that guidance comes from. But that really doesn't follow what we know from basic aerosol physics. And basic aerosol physics says a 5-micron particle will travel beyond 6 feet and will stay aloft for 30 minutes. Smaller than 5 microns will also travel beyond 6 feet and stay aloft for hours. And most of the particles, when we cough, sing, just breathe, are in that smaller size fraction. So the 6-foot distancing is a good rule, but it's also should be thought of as a minimum distance. And if you're indoors, we absolutely have to have other controls in place because the distancing won't matter because the particle concentrations will build up indoors unless you're diluting, air cleaning, or wearing a mask. So you're minimizing how much gets out in the first place.
All right, we've talked about buildings, but a subway car is sort of like a building to me. An airplane is like a building to me in the sense that we're contained.
I agree with you. These are just unique indoor environments, but the same fundamentals apply. So an airplane, it's actually a lower risk environment than most people think. And it's for this reason. You actually get 10 to 20 air changes per hour. Actually, subway cars do a pretty good job of ventilating as well. The problem is, like, I lived in New York City for a while, and if you're on a subway at rush hour, right, the ventilation system is designed for a certain number of people. And if you're in rush hour, right, you could be jammed right in. Then the ventilation system's not really going to help because you're essentially breathing right on top of somebody. There's no way around it. So we still have to de-densify our subway cars and subway as best we can. If we wear a mask, we can really drive down risk. Same thing with buses. You want to open up the windows. They have a ventilation system that's running. We have to be sure it's bringing in as much outdoor as possible. Open up the windows just a little bit can really help. But I should say, most importantly, in all of these environments, school, office, airplane, bus, the engineering controls really help. They really do. But the number one risk-reducing strategy is wearing the mask.
I know you weren't there, but do you have any thought on this? Is this sort of super spreader event in the Rose Garden about 2 weeks ago when the president was sick after, I don't know if he got sick then, but everyone who entered had the antigen, they had a rapid test right there, negative. Yep. There were some people who congregated inside in a little reception, about 15 or 20 people, and then they all went outside, and there was an event that went on for about an hour. And then about 9 or 10 people later tested positive. Any thoughts about that? Is that a sick building and not using what you call the layered approach? I mean, or is that just really bad luck?
Yeah, I think it's more than bad luck. I think it was a matter of when, not if, in terms of when we would have an outbreak in this White House for this exact reason. They relied on a sole strategy, and that was testing. So if someone got by that testing strategy, and then they met in the Rose Garden, they met indoors, they didn't follow basic physical distancing, they weren't wearing masks, right? So they weren't taking these other strategies seriously. I wrote an article in the Washington Post talking about the White House Rose Garden event as a super spreading event. And it's shocking to think that they only had one control in place, that was testing. They don't do this for physical security. I wrote about it in the article. They have a fence. If somebody climbed the fence, they'd probably get dogs. If they got past dogs, they'd meet Secret Service. If they got into the building, who knows what would await them? There's multiple layers of defense here. And so the White House was really grossly irresponsible in terms of the strategies that put in place, strategies that every business I've talked to and every school is actually putting in place. And to your point about what's holistic risk reduction, we talk about this layered defense approach, what we call the hierarchy of controls. There are 5 parts. You eliminate the hazard and prioritize work from home. You substitute activities. Who are the core people that have to be there? Engineering controls is 3rd, healthy building strategies we've been talking about. 4th, administrative controls. How do you de-densify that space? How do you maintain physical distancing? And 5th is PPE, for personal protective equipment. In this case, it's masking. And if you think about that hierarchy, which I've written about going back to April, and it's something my field has used for decades to protect workers, and recognize the White House did one strategy and ignored all the others, well, it's irresponsible. And that's why I agree with Dr. Fauci. It was a super spreading event, definitely. And they were irresponsible in just relying on one strategy to protect the president and everyone around him.
Doctor, thank you very much for joining me.
Thanks so much for having me.
Despite months of success battling coronavirus, Malaysia is facing a surge in cases. Correspondent Dave Grunbaum says Malaysia's businesses are taking a hit.
Hi, welcome. Hi, welcome, sir. Lunch?
Alex Chong hopes to pick up some customers for his restaurant. But this shopping mall is very light on foot traffic at a time of day when it's typically busy.
I'm totally blank. I don't know what to do.
Chong's company owns 9 restaurants, including this one called Lele. After several rough months at the beginning of the coronavirus pandemic, business began to bounce back in August and September. But this month, Chong's restaurants have seen a dramatic drop in customers once again.
So people are just staying at home and they are more afraid.
The reason? Significant increases in the number of confirmed cases of COVID-19 in Malaysia. The country had record high numbers of new cases several days last week. Hakimi Azri enjoyed lunch out with a few friends, but he says occasions like this are becoming rare for him because the rising count of cases has convinced him to spend more time at home.
So I only just go to work and then just go back immediately go back to the house. I can see even for my colleague and my friends, I can see they are doing like that.
Chong says business at his restaurants is down more than 50% compared to just a few weeks ago. He says if this continues for a few more weeks, he might have to close down 2 of his restaurants and lay off about 20 employees.
We'll have to shut down those locations whereby our landlords don't give us rebates. Our landlords don't help us with the rentals.
Lim Brothers Fruits has been serving this Kuala Lumpur neighborhood for 45 years. They're known for their fresh-made spicy fruit salad, but they say business has dropped almost 40% in just the past week. They say they're now barely breaking even and cannot handle any more strain on the bottom line.
Much more fear, concern about the businesses will be affect on the rental of this shop and the salary of our staff.
Welcome.
Just as some local businesses were thinking the worst might be behind them, this resurging health crisis is showing the economy is continuing to struggle. Dave Grunebaum for VOA News, Kuala Lumpur.
Doctors and politicians in Turkey say the government is downplaying the scale of the pandemic. Turkey's government says that each day there are 1,700 new infections and 60 deaths. But doctors say the numbers do not add up. Correspondent Henry Ridgewell tells us more about accusations of a cover-up.
Şanlıurfa in Turkey's Anatolia region is among the cities worst hit by Turkey's coronavirus resurgence, according to official figures. But doctors here say it's far worse than the government is making out. Kenan Gengeç runs a clinic in the city centre.
These days they publish daily official cases of around 1,500 infections nationally, but some days in Şanlıurfa alone we have 600 to 700 cases. It is very obvious that the numbers they publish are not correct.
Those concerns were raised 2 weeks ago by the mayors of Turkey's 2 biggest cities, Istanbul and Ankara. They warned of a mismatch between statistics from the Ministry of Health and the numbers they were receiving locally. Both mayors are from the opposition Republican People's Party. Dr. Gengeç believes the government is trying to limit economic damage.
It is tourism season, and because of this they have economic concerns. They are worried that the public will be angry, and they don't want people to see their failures with such high numbers, so they don't give the correct information.
Turkey's Ministry of Health and the governor of Şanlıurfa province declined interviews with VOA. Şanlıurfa-based journalist Ibrahim Uygur says the government is not providing enough information.
Until 1 month ago, they published how many positive cases were in Şanlıurfa, but now they don't release that information. Now we can only publish the daily number the government gives for all of Turkey.
Şanlıurfa residents also appeared skeptical of government numbers.
I believe that the real numbers are much higher.
The reason why the virus is so prevalent in Şanlıurfa is because no one cares about the rules. They don't wear masks, they are not ashamed. They go to weddings and many catch the virus.
Turkey denies any cover-up. In recent days, the government has imposed new restrictions following a surge in cases. Face masks are now compulsory outside the home, and social gatherings like weddings are limited to 1 hour, with dancing and catering banned. Henry Ridgewell for VOA News.
That is all the time we have for now. Thank you to my guests, Dr. Monica Gandhi and Dr. Joseph Allen. And stay up to date with our website, voanews.com. And follow me on Twitter @Greta. Thank you for being plugged in.